Wonderful. Hello, and thank you for joining us for today's hybrid education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Frozen Shoulder, What You Need to Know. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people infected by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Education programs are open to all. If you would like to hear more about our services or join a community, please visit our website at cscsouthbay.org. Without further ado, I introduce our workshop speaker. Dwight Baldoman is a clinical lead physical therapist for oncology and lymphedema. He is also an orthopedic physical therapy specialist. He's a chapter contributor for the book Multidisciplinary Care of the Head and Neck Cancer Patient. Welcome, Dwight. Thank you so much for being here with us today. And I'm going to share the screen very quickly. Go ahead, Dwight.
Thank you, Rebecca, for the very kind introduction. I'm glad to be back. I was here last year. I'm not sure if anyone in the audience was here. No, okay, that was like around this time, right? So yeah, I'm happy to be here because I really believe in empowerment through knowledge, and I just witnessed that in front of my patients. Like, I have patients who come to us expecting nothing, and then they come out very grateful. Even if, just receiving that information and knowing what to do with that information can make a big difference in one person's cancer journey. So that's one of the reasons why I'm here, and primarily the reason why I'm here today. So let me talk about myself a little bit. I'm Dwight. I have been a physical therapist for over 25 years now, and I started out as an orthopedic specialist, board certified in 2005. Before that, I worked a few years as a general physical therapist, and then board certified in 2005 in orthopedic physical therapy, and then a few years later, 17 years ago, I embarked into the lymphedema oncology field. At that time, I was working where I'm working at now at the hospital, and there was only one oncology lymphedema specialist. And I was just like following her around as a new therapist. And a few months later, she said, "I'm leaving." And she told me, "Why don't you get trained? Nobody else is going to do this." At the time, or maybe still true at this time, not a lot of people want to be in oncology physical therapy because it's intimidating. There's so many things to think about. Patients are, delicate, things like that. And they're just afraid, or not afraid, that's a strong word, but maybe intimidated. So I was hesitating initially, and then eventually I agreed because they sweetened the deal. So 17 years later, lo and behold, I'm glad I did it. I never regret it. I did it. I'm so happy. It added tools in my toolbox, and there's crossover between orthopedic physical therapy and oncology physical therapy. There's so many things that I could address that a general, even a specialist orthopedic physical therapist cannot with the skills that I have. Because somebody with an orthopedic condition may have history of cancer and comes to physical therapy, and a general or even an orthopedic specialist would not be able to know those things. Okay, they might do certain things that could potentially harm a patient who has history of cancer, things like that, and vice versa. All right, so Enough of myself. That was a long introduction. So I usually like to know my audience. So I completely understand if you don't want to share anything like that. But I would like to know why you're here, what you want to learn from this lecture, so I can tailor the information and hopefully you be satisfied when you leave here. Anybody wants to go first? Yes.
It could be a while before it happens. So I'm looking at videos on the internet, trying to figure out and I'm already feeling it. It's real tight. And they just have you dig in and doing certain stretches.
Did you have radiation? Okay, so that's radiation-induced fibrosis.
I had worked shoulder for rotator cuff at the time I got this diagnosis. So I'm still doing therapy. I had to take a break from that. My surgeon. And my rotator cuff is great, but now I'm dealing with all this.
Sure, and that's something that cannot be taken for granted. And we'll talk about that. I mean, feel free to ask questions as we move along. I'm happy to talk to you about that. I have a lot of experience with that and have a good amount of information I can share. Anybody else? Yes.
Yes. I was doing some transplant for my mother 2 years ago, and you have to start over from birth with your immune system, so I had to get every shot. Like my blood's 2 years newborns right now. So anyway, in the meantime, about a year ago, I finished all my shots and the second shingles. And since I did the second shingle shot, I have a pain here and it just won't go away. And
interesting.
I didn't know if that had if it could turn into that.
Sure. We can take a look. I mean, you can share me your things like that, and hopefully, you learn things from here that maybe you will be able to relate to. Anybody else? Yes.
I do. Yes. So I had actually frozen shoulder before I was even diagnosed with cancer. I have calcium chunks in my rotator cuff, I guess. And so I was wondering, am I more susceptible after chemo to it reoccurring?
Typically, when you get, was that a frozen shoulder or calcification of your tendon?
I think the calcification, which totally froze my shoulder up where I couldn't move it. I had to get a cortisone shot.
Yes, so that's a different category. We'll talk about the different categories, and you will learn what your risks are later as we talk about the risks and the classification. Frozen shoulder.
We have two more in person, and now we'll jump over to online. Yes, go ahead.
I had and one side healed really well, and I can exercise and then the second side didn't heal, and so I had to have another operation on it, and it meant that I wasn't able to move my arms at all for a long period of time. That's 6 or 8 weeks. I wasn't able to move my arms or walk or anything, and it now means I don't have. When I first got out of the operation, I had almost full movement. Right now, I'm just
limited. Okay.
Yeah, so
looks like
my arms are different, so I just don't have.
Sure. Okay. Cool.
In the back.
My name's Ben. I'm the husband of Joe. Study sports medicine, but just in the rehab of all of this. I try to help as much as possible. And listen, so between the two of us, we can come up with a bit of a game plan.
Yes.
Sometimes get things quite overwhelming. So that's why.
Very nice. I'm glad that you're here. I hope you'll learn a lot from this lecture, and you'll be able to help Jo with her shoulder.
Knowing what to start again, what do I need to do a certain amount now before the next one, and then start again, and that sort of stuff. So just keeping on top of that, because I've got 6 months more different surgery.
Sure. Yeah. Yes.
I used to have frozen shoulder a couple of years ago, and I did physical therapy and it helped me and it's done.
Yes.
But also I'm a massage therapist and I'm in this field, and I read a lot, and I um, do a lot of exercise and stuff. So I had a lot of clients that they call, and many of them, they say they got pain after shots in the arm and never go away. So I just want to hear what your thoughts about and how you can
address that condition.
Yeah.
Yes, thank you.
Wonderful. We did have a comment in the chat. She has a history of frozen shoulder and recent breast cancer and radiation. All right. Does anyone else online like to share? Oh, Eve, your hand is up. Go ahead.
Oh, hi. Yes, thank you. Well, I didn't have frozen shoulder, but about 4 years ago, I had a reverse shoulder done on my left side. And before I had that done, after I fell, I had swollen, my left arm was swollen. And that swelling between the elbow and the shoulder never went away. And I subsequently had breast cancer on my left breast. So I chose not to have my lymph glands checked and radiation done because I was told it could exacerbate what they're now calling lymphedema, because I still have the swelling in that area on my upper left arm. So I wondered, I mean, is there any possibility that could ever go away, or what I can do about it?
You're asking about the swelling?
Yes.
Is this the arm where you had lymph nodes removed?
I did not have any lymph nodes removed in the breast cancer surgery. I don't know what happened when I had the shoulder surgery. I didn't not knowingly have any lymph nodes removed.
What side was your breast cancer?
Left, and that's where my shoulder was replaced, also on left side.
Okay, and you don't remember having any lymph nodes removed?
No, I did not.
If you don't mind sharing me the stage of your cancer?
Yes, it was stage 1.
Stage 1?
Yes.
Okay. Typically, lymphedema occurs whenever there's a removal of lymph nodes, or radiation. So if you had radiation in your underarm or your chest?
I did not.
You did not?
No.
How long ago did you first notice this?
Well, it was 4 years ago. After I fell and hurt my shoulder, I dislocated my rotator cuff, and that's when the swelling occurred, and it just never went away in the upper part of my arm. It went away in the lower part, but it never went away in the upper part.
Okay, so let's allot maybe 30 minutes at the end of this lecture for questioning. Okay. You don't seem like you have lymphedema. If it's something like that for like the past 4 years and hasn't progressed, it probably is not lymphedema because you never had radiation, never had lymph nodes removed.
No.
Yeah, so it's likely not. But it's good to have it checked, just to make sure.
Okay. I mean, I don't know who I would, have it checked by. I mean, my primary and my oncologist both told me they consider it lymphedema because of the length of time it's been swollen.
Yeah, so I would recommend asking for a lymphedema specialist.
For what?
Physical therapist who specializes in lymphedema.
A physical therapist who specializes in lymphedema?
Yes. So I will leave a link to you, Rebecca, later for a directory of physical therapists that specializes in lymphedema. All you need to do is put in your zip code and you will find those people around your area.
Wonderful.
Okay.
Thank you, Dwight.
Thank you,
everybody. I love the sharing, but I do want to get started on the workshop. And like I mentioned, we will have time for questions at the end. But thank you so much.
All right. Okay. So thank you for sharing. That was very helpful and gives me a lot more insight into like what you're trying to get out of it. So thank you very much. So the objective of this lecture is to hopefully have you learn what is frozen shoulder in the first place, the anatomy of the shoulder, how the shoulder moves, things like that. The different classifications of frozen shoulder, and why there are classifications, why it's important to have classifications, and also the different treatments that are necessary for each particular classification or stage of the frozen shoulder. And then also we'll talk about different exercises that you can do in case you wonder or maybe have some suspicion that you might have a frozen shoulder, because just like with any medical condition, the sooner you address it, the better is your outcome. So, and that applies to frozen shoulder as well. So what is the frozen shoulder? Do you have anybody has any idea? Like, yes. Okay, so you know what it is, right? So frozen shoulder, it's really just lack of mobility in the shoulder. Well, not just, but it can be debilitating if you don't address it. It can be painful, but primarily in the later stages, it becomes more of a disability because of lack of mobility in the shoulder. How do I? Oh, sorry. Okay, so now what separates a frozen shoulder from a regular painful shoulder? That's a tricky question to answer, because the thing is, a frozen shoulder initially is very difficult to diagnose. You may see a doctor, let's say a general practitioner, and you come up to the doctor and say, oh, I have this pain in my shoulder. You do an x-ray, they found nothing. They probably don't have any idea what it is. And then maybe they will tell you, oh, it's rotator cuff, just live with it, or it's an impingement. And even like novice, orthopedic specialists, like surgeons, may not be able to identify this early on. Because what it does is that, especially in the early phase, the patient may have like pain, but they don't know what caused it. So one day they just woke up with pain, they don't know why. And another feature of this, if you do an x-ray, you will find nothing. There's no finding. And usually x-ray is the first imaging that doctors order. They don't order an MRI right away. And if you don't find anything, they send you to the physical therapist. And then a good physical therapist can spot that problem. But if you see a physical therapist who is not specialized in orthopedic, physical therapy, they might not know what it is. It's just for the shoulder, and they may treat you like just anybody with a painful shoulder, not knowing what it is. So the main hallmark of this condition is a pattern of lack of mobility. So the shoulder has 3 planes of movement. So you can go this way, you can go this way, and you can go this way. So there are 3 freedoms of motion of the shoulder. Now, a frozen shoulder would present like a lack of external rotation. So this is external rotation right here. Can anybody online see me? Or can you guys online see me as I show this? Okay.
Now, yes.
Okay. So when I say external rotation, you start with your hands in front of you, elbows by your side, and then you bring your hands out as you keep your elbows glued to your body. Now, if you see one of your arms not moving or has about 50% or less mobility compared to the other side, most likely that's a frozen shoulder. And especially if you feel discomfort, if you push beyond that motion, most likely that's frozen shoulder. So that's what I look for when I see a patient with a painful shoulder, no findings on x-ray, no imaging done. I look at that, and usually if I see that, usually in most cases is a frozen shoulder. Now, in the general population, they say, up to about 5% of people in general can get frozen shoulder. Now, there are 2 different categories. So we have what's called primary frozen shoulder, and then there's a secondary frozen shoulder. So what is a primary? Primary frozen shoulder is when you don't know what caused it. So all of a sudden you woke up with pain. Your shoulder over time becomes stiff and it becomes immobile. So that's primary. We don't know the reason for it. Secondary could be related to a prior injury. Like if you have rotator cuff tear, and then you kept your arm immobilized because it was painful to move, and then it got frozen, got stiff after a while. So that's a secondary. Or let's say you fell on your hand, landed on your shoulder, it hurt, keep it immobile, then that's a secondary frozen shoulder. It is usually related to a prior incident, an injury, and then it becomes a frozen shoulder. Those are the two main categories. In most cases, or in general, women are more affected than men. However, if you're a man and you're diabetic, your prognosis is not very good. So it's hard to treat somebody with diabetes and what I say about the other one? A male and a diabetic person. And then in secondary frozen shoulders, people with diabetes and thyroid issues tend to have higher propensity for getting frozen shoulder. So they say about up to 38% of those people potentially could get frozen shoulder. And also after mastectomy, lymph node dissections, breast cancer surgeries, about 1 out of 5 potentially could get a frozen shoulder. So just think of that. In head and neck cancer, after neck dissections, about 70% of those people get pain in the shoulder. Not necessarily a frozen shoulder, but they have pain in the shoulder. And it is suspected that a good amount of those people have frozen shoulder potentially. And I've seen it myself in the clinic, and it's not just a few. It definitely is. I guess it falls within the secondary form of frozen shoulder, is when you have neck dissection, some people won't be able to raise their arm, especially if that spinal accessory nerve, that nerve that controls the shoulder, runs through the neck, gets stretched out. Because the doctors, when they dissect a neck, if there are cancerous lymph nodes on the nerve, they would scrape it. So even if the nerve is not cut, if you scrape that nerve and stretch it out, it can get paralyzed. And it may recover, but sometimes it takes a while. So a person with a spinal accessory nerve paralysis won't be able to raise their arm. So they can only go up to here. And imagine that shoulder not moving for that long, for so many months. So that could be a reason for it. Before I move on, any questions? All right, good. We don't know. So they just did a study, and then they just found out that people who have this particular diagnosis tend to have more. Yes. So let me show you a video of the anatomy of the shoulder so you can understand better what happens in a frozen shoulder.
Online, when the video plays, please let me know if you cannot see or hear it.
So it's about 7 minutes. I may have to cut it short if I feel like.
The shoulder is an elegant piece of machinery. It has the greatest range of motion of any joint in the body. However, this large range of motion can also lead to shoulder joint problems. Understanding the different parts of the shoulder can help you understand how the shoulder works, how it can be injured, and how challenging recovery can be when the shoulder is injured. The important structures of the shoulder can be divided into several categories. These include bones, joints, ligaments, tendons, muscles, nerves, blood vessels, and bursa. The bones of the shoulder are the humerus, or the upper arm bone, the scapula, or the shoulder blade, and the clavicle, or the collarbone. The roof of the shoulder is formed by a part of the scapula called the acromion. There are actually 4 joints that make up the shoulder. The main shoulder joint, called the glenohumeral joint, is formed where the ball of the humerus fits into a shallow socket on the scapula. This shallow socket is called the glenoid. The acromioclavicular, or AC joint, is where the clavicle meets the acromion. The sternoclavicular, or SC joint, supports the connection of the arms and shoulders to the main skeleton on the front of the chest. A false joint is formed where the shoulder blade glides against the rib cage. This joint, called the scapulothoracic joint, is important because it requires that the muscles surrounding the shoulder blade work together to keep the socket properly aligned during shoulder movement. Articular cartilage is the material that covers the ends of the bones of any synovial joint. Articular cartilage is about 1/4 of an inch thick in most large weight-bearing joints. It is a bit thinner in joints such as the shoulder, which don't normally support weight. Articular cartilage has a rubbery consistency. It is very slippery, which allows the joint surfaces to slide against one another with very little friction. Articular cartilage functions to absorb shock and provide an extremely smooth surface to make motion easier. There are several important ligaments in the shoulder. Ligaments are soft tissue structures that connect bones to bones. The joint capsule is a watertight sac that surrounds a joint. In the shoulder, the joint capsule is formed by a group of ligaments that connect the humerus to the glenoid. These ligaments are the main source of stability for the shoulder. They help hold the shoulder in place and keep it from dislocating. Ligaments attach the clavicle to the acromion in the AC joint. Two ligaments connect the clavicle to the scapula by attaching to the coracoid process, a bony knot.
Okay, I feel like you don't really need to know everything on that. Since he already talked about the capsule, which is what is involved in a frozen shoulder, so I'm just gonna stop the video right there. If you want to continue watching the video, I'll leave the link to Rebecca, and you can ask for the link from her.
I'll email everyone in person and online later today. Thank you.
Okay.
Is that the right one?
Yeah, I
Okay.
think that's the right. All right, so remember the capsule, right? So in a healthy shoulder, that's how the capsule looks like. On your right-hand side, that's a capsule that's inflamed. So the capsule is really like a thick ligament that wraps around the shoulder joint, and it contains the fluid inside it. That's called the synovial fluid. And that fluid is what nourishes your cartilage inside the joint. Now, as you see, if you look at the structure of the shoulder, if you move your arm, what do you think is going to happen to that capsule? It gets wound up, right? For that shoulder to move, you really have to stretch and twist it, right? Because it surrounds around. So imagine that being inflamed and you try to move it. That's going to be very, very, very painful, right? So that's why, frozen shoulder, at least in the first stage, is very painful because it's very inflamed. A lot of blood vessels develop in the capsule itself, and then little nerves grow. And nerves pick up the pain sensation. The more nerves you have in there, the more they can pick up pain. So that's what happens. That's why it's painful. So now we talk about the different stages of frozen. It's very important because this is how we approach treating the frozen shoulder problem. In a stage 1 frozen shoulder, usually there's kind of constant pain. The patient may not be able to sleep at night because no matter what position they're in, there's always pain. And then if they move it, even just a slight movement, it really is very painful. And then this could last up to 3 months. Now, not everybody goes through all the 4 stages. Some skip, like some people jump to stage 2 without having to go to stage 1. Or they may have 2 classifications, 2 stages in between, or they're in between 2 stages, things like that. So it's not a clear-cut category or boundary. And these ranges of duration of each category is just really it's not set in stone. Not everybody follows the same progression. Now in stage 2, the shoulder becomes less painful, still hurts, but it's more equally painful and stiff. In the first stage, to compare, it's really just a lot of pain. There might not be a lot of stiffness, but it's just very painful. The second stage it's equally painful as it's stiff, may or may not affect sleep at this stage. but there's going to be slow progressive loss of mobility at this point. So at this stage, you can really tell when you do this, you can see the difference in the motion between the arms. And this could last between 3 to 9 months if nothing is done about it. In the third stage, this is the frozen stage, and it's stiffer, may not be as painful unless you really crank it and push it beyond its range. And it's, it can last between 9 to 15 months. Then the last stage, which is the thawing stage, there's really not a lot of pain. People may feel like they're back to normal unless they start reaching overhead. And then that's when they realize that they still have a frozen shoulder. There's now almost no pain. It's just very stiff. And then this can last for between 15 to 24 months. Now, why are these classifications very important? Now, if somebody comes to me presenting as a stage 1 frozen shoulder, I would probably say, I want to send you back to your orthopedic doctor or whoever referred you here, somebody who can give you an injection. Because at that stage, there's so much inflammation that there's not much we could do. Maybe we can give them very little exercise they can do at home. And then I would tell them, just come back here after an injection is done and when you're feeling a little better. And also at this stage, we have to be careful because if you're very aggressive, let's say a therapist who doesn't know what they're dealing with and they're like cranking your arm aggressively, what ends up happening is that you proliferate the inflammation even more. And what that does is that it creates more scarring in that capsule. And the capsule gets thicker as a result. And that leads to more lack of mobility later on. So we have to be careful early on. So we don't usually treat them at that stage. I mean, we can, very little. It's not worth coming to us because you can do those things at home. So if, let's say, the primary care can inject you with steroids in the shoulder, fine, but we still have to wait. In most cases, these patients are sent by their primary care to us. And if their primary care is not comfortable injecting the patient, then they go to an orthopedic specialist. It really varies. I mean, these are just arbitrary numbers that they're putting here. It's not set in stone, but this is like just an approximate. Yeah. If you have like stage 1 and it lingers on longer than that, it's probably more than a frozen shoulder at that stage. Yeah, something else is going. You can massage the shoulder as long as you don't crank it and stretch the joint. Yes, yeah. So, I mean, they feel better when you rub their shoulder. Yeah, yeah. So it's good. If you have spasm around the shoulder, you can release it. You feel better. But just be careful not to move the shoulder too much. Yes. Very good question. So this is what I meant by checking for early signs. So if you have suspicion that you have frozen shoulder, just do this motion. Keep your elbow by your side. If you have one shoulder that has only about 30 degrees of external rotation or has about 50% less mobility compared to the other side, then most likely it's a frozen shoulder. And especially if you've been examined by your doctor and doctor says nothing's wrong with your shoulder and you didn't know how it occurred, most likely. And especially if you had a history of frozen shoulder on the other side, highly likely that's a frozen shoulder. Because people who have history of frozen shoulder on one shoulder tend to get frozen shoulder later, a few months, years down the road as well. So how do we inject the shoulder? So the injection happens, let's see.
The glenohumeral joint is usually approached from the front or back of the shoulder.
Sorry.
The glenohumeral joint is usually approached.
Just to be sure. One moment, patience.
Introduction. The shoulder is prone to different kinds of injuries and inflammatory conditions. An intra-articular shoulder injection is a minimally invasive procedure to treat pain and improve shoulder movement. It may be performed with the help of ultrasound or fluoroscopic imaging, which allows your physician to precisely target the intra-articular space. Anatomy. The shoulder consists of two joints. The main joint is the glenohumeral joint, formed by the head of the upper arm bone or humerus and the glenoid cavity at the side of the shoulder blade. The acromioclavicular joint of the shoulder is formed by the clavicle or collarbone and the acromion, a bony projection of the shoulder blade. The shoulder is supported by muscles, tendons, and ligaments. The rotator
go in front or in the back?
What are they injecting?
Oh, what are they injecting? Okay. So typically it's about 20% lidocaine and 40% corticosteroid, usually Kenalog. So it's both, the Kenalog is the steroid, which kills the inflammation, and then the lidocaine gives you instant relief because it's an anesthetic. So that kills the pain instantly, but it may take a few days for that Kenalog work to kill the inflammation. Yeah. So the goal is to kill the inflammation so that the pain stops.
I wasn't really clear. Is it just right into where everything is touching, or is it's into the capsule?
They deliver it inside the joint, in the space. Yeah, because if you want to bathe the capsule, you have to go inside, because remember the capsule is what contains the fluid inside the shoulder, right? So it's that little, I mean not little, but the tissue that contains the shoulder itself. Yeah. So they bathe it, inject it. Now, if you remember, he said ultrasound guided, right? So that's the best way to do it. Some doctors do it blindly, but blind injection is not very accurate. They say 65% accurate or even less. So who knows, you might hit a tendon or another structure and you end up having another problem, right? So it's better to do it ultrasound guided so they know where that needle is going and deliver that medication where it should be. Because if it's not in the proper placement, then it's not gonna do anything to your problem, right? So if, let's say they want to inject it in a joint and then they just injected the bursa, that little sac above it, nothing's gonna happen because there's nothing wrong with that structure. The two bones, the ball and the socket, yes. So that's where they're doing. Yeah, depends if you're dealing with arthritis, yes. But if it's like, outside the knee, because you can have pain outside the knee as well. Yeah. So it depends on the structure. Yes.
We have a question in the chat. Could you prevent frozen shoulder from recurring by exercising the shoulders?
I don't know of any evidence that supports that. However, if you catch it early, you might be able to shorten the duration of the problem. But I don't personally really think you can prevent. I just was seeing this patient. She had mandibulectomy. Do you know what that is? So she had head and neck cancer. Part of her mandible, her jawbone was removed, and it was replaced with her leg bone, like the fibula, reconstructed. I was treating her with swelling in the face. She had difficulty opening the mouth, if you know what that is, trismus. So I was working on improving those two things, and then all of a sudden she had pain in the shoulder. It was a frozen shoulder in the middle of the therapy that we were doing for mouth and the neck swelling. A few months later, she developed frozen shoulder on the left side. So I know she was doing exercises, but she still developed that frozen shoulder on her side. So when it wants to occur, it will occur, no matter what you do, because it's just inflammatory. And the fact that, if it's a primary frozen shoulder, there's really nothing you can do. It's like a thief, it just comes whenever it comes.
for human for inflammation?
Human or like a
Turmeric, it has the
Oh.
curcumin in it. They push that anti-inflammatory.
right. I really cannot speak to. Yeah, it's more like in a systemic kind of introduction of anti-inflammatory. I mean, I know a lot of patients of mine do take a lot of supplements, but I'm not sure if it really works. I mean, that's just my opinion. It does maybe work for some people, but probably not for everybody. Yeah. Yes. Right.
On twice.
Mhm.
On my plantar, I don't really want to go stick it again as well.
Yes.
So I've had to-
So one of the possible adverse reaction of the steroid is the steroid can raise your blood sugar. That's one thing. And if you do it multiple times in one particular area, it can damage your ligaments or tendons, potentially leading to rupture of those tendons. So that's why they don't do it very often. And they don't do it in just a short period of time. So if they repeat it, they wait 6 months, maybe 3 months, you know, things like that. So allow it to recover before they give you another one. Yeah, that's why they try to not give it too many times in one particular area. But if a patient is diabetic, yeah, they're careful. Yeah. Questions?
I have another one.
Yes.
I know about this remedy. It's rubbing alcohol, wintergreen oil, and crushed aspirin.
Mm-hmm.
And you just mix this all together. There's certain measurements, and you apply it topically.
Mm-hmm.
And that's an anti-inflammatory. That would go if you put it right on your shoulder, right?
Well, for it to really work, it has to go deep. I mean, if it has to pass through the skin, it's probably dissipated by the time it gets to the joint, if it does get to the joint. So, you know, placebo is very strong. Oh, what is it?
If you can repeat the question.
Oh, repeat the question. Okay. So the question is, she was asking if a mixture of alcohol, aspirin, and wintergreen oil, a mixture, and rub it on the shoulder. I'm not sure. I'm not an expert in that. But there's a reason why they use needles to introduce steroids inside a joint. It needs a powerful anti-inflammatory. Even if you take it by mouth, it's probably not gonna do very much. Yeah. Right, but if it, let's say it goes to your tissues, but the muscle still receives some of it, and the muscle is highly vascularized, meaning it has a lot of blood vessels in them. So it may deliver it somewhere else instead of it. So I doubt if it does something, but if it couldn't hurt to try. Yeah. So, you know, if it's working for you, go for it. Yeah, sure. I mean, as long as you don't put it in your mouth and it doesn't cause any side effects, go for it. Yes. So a question about biofreeze and other topicals. It's not a cure, but it can help you, you know, survive maybe a couple hours without having to take medication. No, biofreeze is really just kind of fooling your brain to think that, yes, so instead of feeling the pain, you feel the coolness. Yeah, so it tricks you. That's pretty much it. Yes. Yeah, the same with salonpas. Yes. Mm-hmm. Yeah, some of them have lidocaine. Yes. Yeah. Well, I've had patients who swear by acupuncture. Yeah. Yeah. I well, it may help with the pain, but I doubt if it does help with mobility. Sure. All right. Yes. So what? Sure. Sure. I mean, if you can, that's the best way to go. All right. So
I have a question.
Yes.
You know, if you have if you have cancer on the left side, do you expect the frozen shoulder to be on the left side?
Not necessarily.
Huh?
Not necessarily. If, let's say it's a secondary frozen shoulder, and you had lymph nodes removed on that side, there's a higher likelihood that you're going to get it on that side. But if it's a primary frozen shoulder, it's going to attack any side of your body.
I see. And if you're a swimmer, after your chemotherapy and radiation, a lap swimmer, should you worry about developing frozen shoulder, or just go ahead and exercise your lap swimming?
Yeah, continue moving. That's your best, you try not to limit yourself, because if you're gonna get it, you're gonna get it anyway. It's not gonna, nobody can stop it.
I see. Okay, thank you so much.
You're welcome. So let's move on to the treatments. So with physical therapy, we do joint mobilization. So if you come physical therapy and you came in and was smiling as you left the clinic, you probably didn't get what you deserved. Not that you're being naughty, but you really need to be aggressive with this, okay? Because if you're in therapy, you're just getting electrical stimulation, hot pack, maybe stretch you for a little bit, give you exercise. That's not what you need. If your eyes are not welling while in therapy, you're not getting enough, okay? So I always warn my patients, maybe you've heard about physical therapy as physical torture, right? In the majority of cases, that's not true, okay? So you come into us, you feel better after you leave, okay? We're there to make you feel better, to ease your pain. But in this situation, we're dealing with very stiff structures. We need to stretch it out, and in the process of doing so, we're gonna inflict some pain. Now, it doesn't have to be really, really painful. I mean, that's why I always communicate with my patients during treatment. Because I do try to gauge how much they can handle. I'm not gonna force it if they cannot, because I want them to come back, right? So a skilled physical therapist can push it, and not to the point of causing too much pain. Because there are so many variables. You gotta look at the face, you gotta feel the contraction of the muscles as you're mobilizing the joint. So a skilled physical therapist can make it a pleasant experience, maybe not so unpleasant experience in the clinic. So we really need to stretch it out. And also, when you're trying to stretch, you have to really hold it for a long time. So what's a long time? So you've probably been to physical therapy, right? Most of you, and they tell you to hold it for 10 seconds. That's not gonna cut it. I usually go for a minute to hold. Because I use the analogy of a rubber band. If you stretch it and hold it for like 2 seconds, nothing can happen, right? If you really want to change, you hold it longer and release it, then it's changed. Because you want to deform the capsule. You want to deform it and keep it there so that you have restoration of that shoulder movement. So there's a lot of stretching. There's a lot of joint mobilization. Like we, jump on your shoulder, not jump, but yeah, like really move it, very aggressively moving it, communicating with the patient. So after we restore mobility, because in most cases, when a person gets to the point where they cannot raise their arm up, most likely the muscles around the shoulder and scapula, the wing bone, has gotten weak over time. It's easy to lose muscles. In just a couple of weeks of not moving an arm or a leg, you can see the muscle shrinking. So we need to restore those muscles after we regain most of the mobility back. So that's what physical therapy does in a frozen shoulder. They may use certain modalities, but I would say if your therapist is spending so much time with electrical stimulation, with ultrasound and things like that, it's a waste of time. Spend more time stretching and exercising. That's what makes a difference. Unless you're in so much pain that you cannot do things like stretching and exercise, well, in that case, you don't belong in therapy anyway. You need to have an injection done and then come back to us when you're ready, when you're not in so much pain anymore. Because remember, we don't want to aggressively stretch something that's so inflamed. You end up causing more scarring and more thinning of that capsule, and then you end up having a more severe frozen shoulder later down the road. We don't want that. Yes.
Synovial fluid movement.
Mm-hmm.
Breathe into it and it moves, it takes it out of pockets and moves it.
Mm-hmm.
Does that kind of stave off inflammation?
Okay.
Or
Yes. So the question is, you know, if you're moving your shoulder, like when you're in yoga, and you're circulating the synovial fluid, the fluid inside the shoulder, will that stave off inflammation? It depends. If you're in the first stage, most likely you're going to cause more inflammation. But if you've progressed to the second stage, third stage, it's beneficial. You know, you gotta move it, keep moving. Yeah. I mean, to a certain degree, it can help. Even in a stage 1, you just have to be careful not to overdo things, and your margin of error is very small.
ever in your life when you're doing this?
Well, exercise can be anti-inflammatory. I mean, it can help you, you know, stave off, you know, those things. Yeah. So, you know, exercise is the best medicine. There's no side effects unless you fall and hurt your ankle. Yes, for any joint, that's a good thing, because the joint. So remember that cartilage at the end of the bone? Those doesn't have blood vessels in them. So where do they get their nutrition? From that synovial fluid, right? And they're like sponges. A sponge doesn't take in the water if you don't squeeze it. So a joint or a knee, let's say or a shoulder that doesn't have stimulation, like banging those two bones together, that cartilage is going to get worn out over time because it's going to starve to death because it's not getting in the nutrition it needs. So it needs a stimulation by movement. Exercise is what has.
I have a question.
Go ahead, online.
Go ahead, yeah.
How can you differentiate between arthritis, inflammation of arthritis versus frozen shoulder?
Good question. So arthritis, it depends on what arthritis are we talking about. Are we talking about osteoarthritis, where the bone becomes worn out, like bone on bone, or
osteoarthritis?
Yes. So there's usually evidence on the X-ray with that. So if your doctor took an X-ray, you can see that it's arthritic because there's wearing out of the bones and cartilage. In frozen shoulder, you don't see that. So that's why when your doctor X-rays you, he says nothing's wrong with your shoulder. Go to physical therapy. So that's one way to differentiate it. Now, in an arthritic shoulder, osteoarthritic shoulder, you may hear clunking, clicking every time you move the arm. It doesn't follow the pattern of limitation where when you do that maneuver I just showed you earlier with your two arms.
Yeah.
You don't see that, you know, asymmetry. That's significant limitation, yeah. Because if it's like 50% or less, that's likely a frozen shoulder. You may have limitation with osteoarthritis, but not that much.
I see. Thank you so much. Thank you.
Yes.
Go ahead.
It does, yes, over time. Yes. So the question is, as you age, you have less synovial fluid, and that also happens in you know, as arthritic shoulders or knees or whatever synovial joint you have. That's why they give you hyaluronic acid to inject. Remember, or if you've heard about that type of treatment, they give you that to kind of replace the synovial fluid. Because the arthritic joint have less of those, and then they put more in. There's no way you can really prevent that from happening. It's just part of, you know, being a human. You know, eventually, kind of. There's no research to like solids evidence to support that. But you know how the industry is pushing for it. So yeah, if you have the money to burn, yeah, go for it. And if it makes you feel better. Okay, all right, so let's continue. I'm gonna be here for a few more minutes after I'm done with the lecture to answer questions. I can stay longer if there are more. Two, yeah, okay. Okay. Which one is oh, repeat?
Yeah.
Repeat it?
Yeah.
Okay. So the question is, can you prevent loss of hyaluronic or synovial fluid? I'm not aware of anything that you can do to prevent it from happening. It's just part of being human. As we age, we tend to lose some. Just like, you know, when you're older, you lose collagen in your skin and your skin gets drier. Maybe there are supplements out there. I'm not into that. I don't put makeup or whatever, so I don't know how that impacts. I'm sure there are some out there, yeah, but it's not mainstream maybe yet. Okay, right. Okay, so moving on. So this particular exercise is something you probably can handle if you have a stage 1 frozen shoulder. If you suspect you have frozen shoulder, unless it's very painful and you're concerned about proliferating scarring in the area, this is something that can be done. What is done here is that the person is really just using his body momentum to swing the arm, okay? So he's not actively doing this. What he's doing is his one hand is supported by a furniture maybe, and then he's just rocking back and forth his body. So as you can see, I'm not using the muscles. So you can go forward, you can go sideways, and then you can go circles. Okay, so the arm stays limp. You're not activating any muscle at all because you want that what you said about the synovial fluid circulating. That's gonna be helpful, and that can be tolerated when you have a stage 1, and it's not very aggressive. So you're not really stretching that much. Yeah.
And for those online, if you're unaware, so right now the presentation should look very big and Dwight should be very small on the right. But in between the two boxes is like two little lines. That's a toggle. So if you click on that and move it to the left, presentation will become smaller and Dwight will become bigger. So for those online, you can move that back and forth as you see fit when you want to look at Dwight bigger or when you want to see the presentation bigger. So I just want to give everyone that little tip. Go ahead. Thank you.
So that's what we call is the pendulum circle. So yeah, a pendulum just swings, right? So that's why it's called a pendulum, or Cudman, whoever invented it, I guess. And then these two can be tolerated. So the same principle, you can just kind of rock back and forth. So there's no active arm movement. So a person may be sitting next to a dining table and they're just like rocking their body forward and back. So the arm is really just sliding on the table with a towel, preferably under the arm to reduce the friction between the skin and the table. And that can also potentially be easily tolerated in stage 1. So as you can see, you know, there are two positions. One is forward, and then the other one is at an angle, 45 degrees. The 45-degree angle might be less tolerable, but for sure, again, depends on how irritable the shoulder is. You know, the first one may be tolerated okay. So those are potential exercises. Of course, these are just sample exercises that I'm sure there are a lot out there that can be done, but you know, just for today's information purposes, I'm just putting it out there in case you're interested in them. In stage 2, where there's maybe not as much pain and maybe you're dealing with more stiffness, so you can start doing things like this. So if you have a cane at home, or you have a stick that you can use, you lie on your back and you just kind of use your good arm to stretch the other arm that way. Or if you've seen a shoulder pulley, like what you see at the bottom there, that can also be useful. So you're pretty much using your good arm to stretch the bad arm. And then when you're in 3 or 4, so these two are a little more aggressive than the previous 2 slides. These can be tolerated fine when you're in the later stages. So the first one is just using a towel. So most people with frozen shoulder will have difficulty reaching behind back. Like this motion is very difficult for them. Usually this is the last return. So that motion right there and the second picture is how you try to restore that movement. So that would be like necessary for like women if they want to try to hook their bra from behind. They need to be able to get up there. Yeah. Yeah. Okay, so this is like my favorite exercise because in my experience, if you address this motion, so remember there are 3 planes of movement in the shoulder, right? So forward, up and down, forward, and then side, up and down, and then you have the rotation. Now, if you address this first, the other 2 motions follow. So you're killing 3 birds with 1 stone if you can tolerate this particular exercise. So it's a good one to do. So this is my go-to exercise. So if I have somebody put a gun on my head and have a frozen shoulder patient in front of me, give him exercise. So this is what I give him. It's very useful. It's really a good exercise to do. You just have to be mindful not to let your elbow move away from your body so you get to the shoulder. Yeah, but hold it a minute at a time. Do it for 5 times in a day. Should be good enough. That's okay. Let's look at the video. It's only a minute.
As you do the shoulder external rotation stretch with a stick, you want to make sure that you are standing against a wall. This will make sure that your body isn't compensating or trying to rotate out of the stretch. You want to grab a stick that isn't too heavy and that you can put your hand on the edge of the stick to where your thumb is facing up towards the ceiling. You don't want to be gripping the stick with your palm down. You want to just be holding onto the edge, again, with your thumb facing up towards the ceiling. You want to tuck your elbow in so that way it's directly at the side of your body. Make sure that your elbow does not come away from your body as you're doing the stretch. You want to make sure that your shoulder, your elbow, and your wrist stay in a neutral position. With the opposite arm that you aren't trying to stretch, you want to gently push the hand away in a direction of external rotation of the shoulder. Once you get to a point of a mild to moderate stretch and not pain, you want to maintain that position for approximately 1 minute. Repeat this stretch 3 times.
Any question on that exercise? Do we have a stick? Oh, no worries.
So Dwight found.
So what you do is, let's say the person is holding it up. What I do is I grab the other hand like so, and with my thumb up, and then I use the other hand to push my left hand away from my body while keeping my elbow stuck to my side. Okay, because if this elbow moves away from me, then you're not getting to the capsule. You're stretching something else. So you really have to keep it glued to your body as you're pushing it. Like that. And you hold it. So remember, a minute is the magic duration. Okay. 10 seconds is not going to cut it. Yeah.
That seems like a long time.
It is a long time. So you have to really look at the clock because, when you're torturing yourself, you want to keep it as short as possible, right? So having a clock in front of you makes a huge difference. You can really stick to it. Okay. Well, if you're in stage 3 or 4, it's not that much pain anymore at that stage, you can go hard, yeah. But if you're like stage 2, you know, you have to be a little gentle. Is, you know, I would say, you know, the pain rating, right? Between 0 to 1 to 10 or 0 to 10. Stay at 3 or 4 level and stay there. So you can hold it for a minute, because it gets to like a 4 or 5, that's harder to tolerate. Yeah, so it's more challenging, because when you're feeling pulling already, you're doing something, okay? So you're not feeling that pulling for nothing. There's something going on in there. You're stretching already, so let's hold it, yeah. All right, so that's the magic exercise. All right, so it's time for questions. Mm-hmm.
Does that mean I don't have frozen shoulder?
Okay.
Even though I can't?
Can I have you come over?
All right, so keep your elbow to the side.